Medurstand. Understanding Medicine.
I am Professor Aziz-ur-Rehman, and in the series of videos on ECG titled Interpretation of ECG, today we are going to talk about the next topic. And since we are going to start with acute coronary syndrome and ischemic heart disease, this lecture is basically an introductory lecture, which is very important to understand before you go to the rest of the videos regarding ischemic heart disease. This is the total agenda. We have already covered introduction and we have already covered how to determine cardiac access, and today we are going to take up this topic. Coronary anatomy and pathogenesis of infarction. Of course, I will not go into the detail a cardiologist would want to or a interventionist would want to. I will just give you some very brief physiology and anatomy of coronary arteries, because that is important to understand myocardial infarction, which area is infarcted and which artery may be involved. And I will also discuss the pathogenesis of the infarction process, because that will also help you to understand what type of infarction. Is it STEMI or is it NSTEMI, or is it which part of the myocardium is affected? So this video is essential to understand remaining 4 or 5 videos on ischemic heart disease. This is our heart. We have mainly two arterial systems, left and right. This one, of course, is the left one. There's a main stem which arises from the aorta, and this passes behind the pulmonary trunk. That is why it is slightly fainted here. And then it bifurcates into two major vessels. One is left anterior descending artery. This is abbreviated as LAD, left anterior descending artery. Then we have another one going back through the sulcus between left atrium and left ventricle, going back, and this is called left circumflex artery. And on the right side we have a right coronary artery. So that arises again from the aorta, passes between the sulcus of the right atrium and right ventricle. Branches are given to the right atrium, right ventricle, and then turns around and provides the posterior surface and the inferior surface of the heart. This is shown in slightly more detail in the next slide. For example, this is the left circumflex. This would supply left lateral side, this one. And you know, left lateral side is reflected in limb lead 1 and limb lead AVL and also V5, V6. So if this artery is occluded, perhaps the changes will be seen in the lead just described. And it would also supply the posterior wall. So that might result in posterior wall infarction. Left anterior descending artery, this one shown with this arrow, it supplies the anterior wall of the left ventricle and also the anterior two-third of the interventricular septum. So if left anterior LAD is affected, this part will be infarcted. Now on the right coronary artery, it supplies right ventricle, anterior surface, this part, but it also supplies the inferior wall. Now there is an artery here, this is called posterior descending artery. Like we have left anterior descending artery, we also have posterior descending artery. This may be supplied by either right coronary artery or left coronary artery. Mostly in about 80% of the cases, it is supplied by the right coronary artery. So right coronary artery would result, if there is a distal occlusion, may result in true posterior infarction or posterior wall of the left ventricle. So whichever artery, right or left coronary artery, supplies the posterior descending artery, that is described as dominant system in the terms of cardiology. This is the ECG representation, and the previous was arterial representation of various walls, and this is the ECG representation. Now imagine this is the cut section of the heart. Now this is left ventricle. Septum is generally considered to be part of left ventricle, and this slit-like structure is the right ventricle. and infarction usually affects left ventricle and the septum. Of course, it can affect the right ventricle also. That is called right ventricular infarction. That is relatively recently recognized condition. It may have some important hemodynamic bearings. I would discuss that in a separate video. But here, I think you can imagine that left ventricle consists of the septum and the left ventricular anterior wall and the lateral wall going back into the posterior wall. And this is represented by precordial leads. V1, V2 would represent anteroseptal part, V3 and V4 anteroapical part, and V5 and V6 anterolateral part. Anteroapic, anteroseptal, anteroapical, anterolateral. The word antero means this all actually are part of anterior wall. So these leads, if there is infarction in this part because of left anterior descending artery disease, it would show in the form of ECG changes in these leads. Similarly, we have an inferior wall representation, and inferior wall is represented by limb leads 2, 3, and AVF. Inferior wall is not represented by precordial leads. So whenever you suspect inferior wall infarction, that would occur as a result of right coronary artery occlusion, then you will look for changes in lead 2, 3, and AVF. Now this is high lateral. Left circumflex artery, if that is affected, that may involve this part only. Now this may be shown only in limb leads 1 and AVL if this is high lateral. If this is lower part of the lateral, then it might show in left precordial leads also V5, V6. So you need to understand this lead representation of various parts of the myocardium so that you can localize infarction and you can also identify the culprit artery. And as you must have realized that there is no lead system which represent the posterior wall, and this is the posterior wall of left ventricle, which may get infarcted as a result of either right coronary artery disease or left circumflex disease. So this is not represented by any lead. So what we do is, actually in experiment labs, you could extend these leads from V6 further down to V7, V8, V9. You could place leads on the posterior wall. If you do that, then these leads would represent the true posterior wall and it would show the same changes which we are going to discuss. But if we do not have these additional leads, then we can look for reciprocal changes in opposite leads. Now in electrophysiology, whatever change you see here in these leads, just the opposite will be seen in opposite leads. So I think this concept will be further highlighted when we take up this in posterior wall infarction. But at this level, just understand that we would look for reciprocal changes of infarction in the opposite leads representing true posterior wall. So in this case, V1, V3, V4, like that. This is another important concept we need to understand before we take up individual modules. Now, suppose this is the heart and this is the left ventricular wall and this is infarctor. We have different leads. Some are placed on the part which is just over the infarctor part. The other lead may be placed just on the opposite direction. Now, in the case of infarction, in the phase of repolarization, heart does not get repolarized. It remains in a permanent state of depolarization and it continues to produce current. And this is called current of injury. Now, any current which flows toward an electrode, it would be recorded as upward deflection. And when it comes to ST segment, it would be recorded as ST segment elevation. If this is the infarctor part, this produces current, and this is the electrode, this would record as ST segment elevation and also other changes, but here I'm going to emphasize on ST segment elevation because that is the hallmark of acute infarction. So this is one thing, and any lead placed on the opposite side would record the same electrical activity as ST depression, because in this case current is flowing away from this part. So electrode is here, current is flowing in this direction, and this would record the same pathological phenomenon, same current of injury as ST depression. So whenever we look for infarction, we would look for ST segment elevation in the infarctor part, and there may be additional changes which are ST depression in the opposite group of leads. So the primary pathology will be localized on the basis of ST segment elevation, not ST depression. There are certain lead groups because different areas are supplied by different arteries, and there are certain group. For example, one which is easiest to understand is lead 2, 3 and AVF, because this represent inferior wall. Then this one is coded green 1 and AVL, and then V5, V6. 1 AVL, V5, V6, they represent lateral side. AVR is the cavity, and this usually does not represent any particular part of myocardium which is infarcted. Then this blue is coded V3 and V4. This is the lateral wall, the lower lateral wall, and of course the continuation of anterior wall, but to the lateral side. And V1, V2 is the septal part. Now, in cases of extensive anterior wall infarction, you would have changes in V1, V2, V3, V4, V5, V6, all 6 leads. But it is possible that only right-sided or left-sided or the middle part is infarcted. So accordingly, we would say anteroseptal, anteroapical, or anterolateral infarction. Or we have already discussed the inferior wall infarction. So this chart might help you to memorize which group of leads represent which part of myocardium which may be infarcted. This is another important slide. I have now described the arterial distribution. I have also described the ECG placement, various ECGs representing various areas. But now I'm going to show you the pathogenesis of myocardial infarction, which will follow the electrical equivalent of this infarction. Now, this is the myocardium, the coronary artery. This is the coronary artery, and this yellow is the atherosclerotic plaque. It was causing some narrowing, maybe a little bit of angina, nothing more than that. But then this blue part shows that atheroma got ruptured. It attracted platelets, and platelet caused significant occlusion of coronary artery, but not complete occlusion. So it resulted in ischemia, which caused prolonged resting chest pain, but it did not result in any actual infarction. So since there was no infarction, there would be no ST segment elevation, and troponins will also be negative. And this condition is called unstable angina. Another one, if the same thing, but in this case, clot was slightly bigger and it caused more critical ischemia, and it resulted in infarction, but only confined to the endocardium. Because whenever there is ischemia, it is the endocardial part which is affected first. Because coronary arteries are present on the surface and they penetrate inward in any irrigation system or any circulation. If there is drop in pressure, if there is compromised circulation, it is always the distal most part which is affected first. So this would be affected. This would not cause ST segment elevation, but the troponins will be elevated because there is necrosis, there is damage to the myocardium, so troponins will be elevated, but ST segment will not be elevated because that requires transmural full thickness infarction, and this is called NSTEMI, non-ST segment elevation infarction. It is infarction. It would require acute emergency management. It might require revascularization and other things, but it is not ST segment elevation myocardial infarction. Third one, the same disease process, but in this case, the person was a little unlucky and ought to present late. The clot was bigger and it caused almost complete occlusion of coronary artery. And this resulted in transmural infarction because there is ischemia throughout the myocardium. This caused transmural infarction, and that would cause ST segment elevation. And troponins will also be elevated, of course. And this condition is called STEMI, ST segment elevation myocardial infarction. Typical concept of myocardial infarction is related to STEMI. Now, please note down, I'm emphasizing on ST segment elevation because once that is present, patient will follow a certain trajectory. If there is no ST segment elevation, there will be a separate trajectory, but both are infarctions. Both carries serious risk associated with them. And we are going to now discuss the electrical changes which occur in this type of infarction and this type of infarction so that we can make a diagnosis of three things: whether or not there is infarction, number two, if it is ST segment elevation type infarction or non-ST segment elevation myocardial infarction, and number three, which artery is likely to be the culprit. So that is what we expect from a good physician and a good student. This is the full thickness infarction. Now this is the myocardium. This is the coronary artery, that particular branch. Let's imagine left anterior descending artery, and this is completely occluded. So if this is completely occluded, it would compromise the circulation going into the myocardium, and that would result in myocardial damage. And myocardial damage always starts from the endocardium, and it would extend outward like this one. So this infarction extends and affects the entire myocardium. This entire process may take few minutes to several hours. This process may be few minutes to several hours, and as this evolves, there will be ECG changes. And ECG changes any lead which represent this infarction, and if this is left anterior descending artery, and this would be then one of the anterior leads like V2, V3, and this is the ST segment elevation. So you would see ST segment elevation and also T-wave inversion. This is because of the current injury. This part, which is undergoing necrosis, is producing current of injury, and that is producing ST segment elevation. And the same abnormality would cause changes opposite in the opposite lead. The reciprocal leads would show ST depression. Okay, so we will localize infarction based on ST segment elevation, not ST depression. So this is full thickness infarction. Full thickness infarction is required for ST segment elevation. Now let's take the example of non-full thickness infarction. This is the clot. It is causing only 60%, 50% occlusion. It would compromise circulation, and infarction would start from the endocardium, but it might not reach the surface. So it would cause non-full thickness infarction, and it would cause non-ST segment elevation myocardial infarction. In this case, the changes would be seen. Current of injury is flowing away because this is normal myocardium. This is depolarizing, repolarizing in a normal way. Only this part is producing current of injury, and this is affecting the other side more than this side. And current is flowing away from these leads. These are different leads. These are placed here, and there would be ST depression in multiple leads. Now, it is also important because localization of infarction is based on ST segment elevation. And in this type of infarction, there is no ST segment elevation, so you will not be able to localize infarction. You will not be able to actually identify the culprit artery. This is as far as the theory goes, although the experts may be able to still make a very good guess which artery is involved. But since ST segment elevation does not occur in non-full thickness infarction, it is usually not possible to exactly pinpoint the culprit artery. The changes are ST depression and T-wave inversion. So now we proceed further. Evolution of infarction. This is how infarction develops. These are the changes. First change is hyperacute T wave in those leads which represent the area infarct. This change is very fast. It occurs, it comes and then goes. Only those patients who present to the hospital very early or those who develop myocardial infarction while they were already in the hospital, they would show these changes, hyperacute T wave as shown here. This would be a temporary change. It must evolve into further changes. If it persists, that means it may be due to some other cause. There are other causes of T wave, hyperacute T wave. ST elevation with the reciprocal ST depression. We are talking about full thickness infarction. This is ST segment elevation, and in the opposite lead there may be ST depression. And this ST segment elevation has a particular morphology. It is convex upward, and it is seen in those leads which represent that part which is infarcted. And it would be followed by T wave inversion. While ST segment is still elevated, there would be T wave inversion. So there is overlap. First is a hyperacute T wave, then there is ST segment elevation, then there is T wave inversion, and there is overlap. When the one change is still there, the second change start developing. So typically in one patient, you would see multiple abnormalities. Finally, Q wave develops, and Q wave is considered to be permanent change, although in some cases it might disappear, but ultimately patient may become just ST segment and T wave becomes normal, but T wave persists. So you have hyperacute T wave here, ST segment elevation and inverted T wave with Q waves, and here ST segment is settling, Q wave is still there, and this is the final ECG. After several days to weeks, patient would have just Q wave and STT changes have already been normalized. So these are the changes which we will look for in different leads in subsequent videos. So that was it. I'm Professor Aziz-ur-Rehman. We covered anatomy of coronary vessels. We also discussed the area supplied, and we also discussed the pathogenesis of full thickness infarction, pathogenesis of non-full thickness infarction, and how these infarctions result in different type of ECG changes, ST segment elevation type of myocardial infarction, non-ST segment elevation myocardial infarction, and we have also learned what are the changes which develop in acute myocardial infarction, hyperacute T wave, ST segment elevation, T wave inversion, and then normalization of FCT and the persistence of Q wave. So we will discuss these changes further in subsequent slides. And thank you very much for joining me on Medurstand, and I really look forward to see you in my next video.